we use the ECHO model, which is the extension of community health outcomes. And so this model of dissemination was created to bring teams of experts and people from the field together over distances. And so it's really hoping to better provide caregivers and teachers and early childhood teachers and social workers and therapists the tools they need to serve people in under and unserved populations and communities where they don't have access to all of the trainings that might come along with more urban settings. So thank you, Navita, for sharing that. So you have a very unique perspective and something I hope you'll share as we go along. We have a small group today, so we'll try to make it more of a conversation. So today I will be presenting on the, sorry, I can only do one thing. It's very hard for me to talk and do other things. Here we go. Can y'all see my screen? We'll be talking about the developmental outcomes for a lot of our children who have been exposed to either opioids and they've had a diagnosis of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, or just other substances in general, because we know that it is hard to kind of tease out effects of different substances because there's so much polysubstance use.
Sarah, did you want to start the slideshow, or
do you not?
Program? We only see.
Oh, you know what? I'll just keep it like this. But thank you, John.
Okay.
So these guidelines are, many of them were brought, and we can follow guidelines from the Centers of Disease Control, the CDC, and the American Academy of Pediatrics. And today we'll go through, it's kind of a loaded topic. So I'm hoping to present it through the lens of infant mental health and how important the relationships are in development and attachment, and how a caring and supportive care, sorry, let me start over. A responsive, sensitive, and supportive caregiver really impacts development for children who've been exposed in utero. So I wanted to start kind of just with this frame of reference of the circle of security. I don't know if all of you are familiar with it, but it's a model often used in attachment. And we want to consider ourselves or caregivers of any capacity as a secure base and a safe haven. And we know that the development of children and the parents or caregivers is actually a transactional relationship where there's a lot of give and take, and we're learning from the children and the children are learning from us. And that give and take shapes our responses to them, and then their responses back to us, and lays that developmental foundation for the other areas of development. So I often consider social emotional development the primary focus when, and the area that we need to focus on before children have the capacity to develop in other areas. So as described, circle security, we form the secure base, or, we try to form a secure attachment with children or caregivers. And I'm talking as a parent today, but sorry, I'll try to keep my chat open. And so, children need to feel secure before they're feeling confident to explore their environment, to explore relationships with others, to, even physically crawl away from parents on the floor. If they're not feeling secure within themselves and don't have that internal working model that a secure attachment provides them, they're going to really have a difficult time developing regulation within themselves and the organization to go out into their world and learn about it. And so I just thought it was a nice example because it provides a little bit more of an idea of what older children might need from their parents or caregivers, teachers, whatever. And that we know that all development happens within a relationship. There's a famous phrase that there is no such thing as a baby, and that just kind of refers to the need for babies to have those really supportive and safe caregiving relationships. And so within this model, we think of dilemmas that come up in relationships, kind of those mismatches or the serve and returns that don't form a good connection, but we need to remember that repair in those back and forth interactions and those circles of communication are actually the most important part of the relationship. You don't want to leave a mismatch or miscommunication without coming back and offering some sort of repair in that relationship or that interaction. And that these repairs and the interventions that parents use, caregivers use, are not just about how the child needs to be included, but how adults are able to expand their understanding of the child. So it's really going back to that transactional relationship and growth of both the parent and the children. Any thoughts? That's a lot, and it's one slide. So I know it can kind of be much, but I just kind of wanted to lay the context for other areas and what we might be seeing in the children we know and love. So on these slides were actually created by the Project Scope team at the University of Wyoming and the Ohio State University and the University of Cincinnati. So I think we need to recognize that this is important information and findings from studies, but at the same time, keeping in mind that we don't always know the context that these studies were, that these children were in, like the situational context or the living context, or what types of caregiving they had in these studies. So we do know, so I just want to hold that aside, that a lot of this information is important, but it can be very, it's very situational, and development really, we need to take into account the importance of that relationship and that with the parent and the caregiver. But we do know prenatally that opioids and other drugs such as meth and alcohol definitely affect brain development because it is passed through the placenta, and that we have seen differences in areas such as the amygdala, where that's, our fight, flight, or freeze brain structure, in the limbic system. And so when we do see these differences in the brain connections, we can expect kids to be more sensitive and have a harder time regulating themselves, which again leads to learning all sorts of different skills in life. And then the reduced gray matter, we know that the gray matter is often is very important in developing cognition and higher level thinking and reasoning of the cortex. So when that is compromised, we need to step in as providers and parents and supportive people, adults in children's relationship, to really understand that that's going to impact their impulsiveness, their ability to concentrate and have the attention they need for tasks. And again, really just holding that in mind as we see children and as they grow and get into more complex developmental levels and systems. We also know that vision development can be impacted by the use of substances in utero, and that the occipital lobe really, a lot of these visual impairments aren't necessarily what is happening in the cornea or the eye itself, but it's actually either directly related to the brain development in the occipital lobe, which is our vision center, or how the optic nerve interacts with different types of the brain. And so we just really need to be mindful that we are getting our children evaluated by, optometrists or ophthalmologists who are more familiar with functional vision and not just the health of the eye itself, especially if we're seeing difficulties with reading or concentration or motor skills. We just need to know that this is an area that's often impacted. So, and it often gets overlooked. So that's why I'm stressing it first. Okay, motor development. This, I think if anybody's had, I know Christine, if your babies were in the NICU for a while and had to, have morphine to help them go through the withdrawal process, then you might have seen some of these motor skills or the atypical motor patterns. Babies can be very fidgety. They can, almost looks like tremor. A lot of times it looks like tremors. Right. So Christy, I see your chat. I actually I'm not sure that there's somebody. That's okay. Let's just make it a conversation. I'm not sure that there's somebody here in Flagstaff. I've been really hoping and asking, advocating for the Children's Health Center at the hospital to start bringing a specialist up from Children's. But I think the best advice I can give you is there are providers, and it's usually a developmental ophthalmologist at Children's, but I think maybe some other, Lisa, I'm not sure if you know of a practice, or Nicole, since you've worked in it in the area. There's definitely other providers in Phoenix and in the southern regions of the state. But if you have resources, everybody go ahead and share them in the chat. That would be wonderful to connect that's the point of this, to make a community of practice and to really spread and share our information. So the motor development, we also see hypertonicity. So really kids with maybe more exposure or more frequent exposure or longer durations of exposure often have higher muscle tone, and they may have really hard time kind of relaxing those muscles and being available to regulate themselves. Because hypertonicity, it really affects not only their comfort, but also their ability to relax and kind of organize themselves, to get into a good position for feeding or sleep. And it can impact their meeting their motor milestones later on as they go through, especially the first year of life. So thanks, Lisa and Nicole. The motor skills have been found to be some delay in children. And again, I can't tell you if these studies, what type of exposure the children had, whether it was right up until the end of development or the end of pregnancy, or if it was earlier on. I do think, obviously, the longer mom or children are exposed in utero, the higher the likelihood that their motor skills are going to be impacted. And especially if they've had a situation of hypertonicity or high tone in early infant or early toddler or infancy, then you're going to see more of an impact, a longer lasting impact into childhood. So it's always a good thing to keep in mind, a good idea to keep in mind as they go on through childhood, to that their prenatal exposure can be impacting their motor skills. So a lot of times you'll see that they're later on when they're getting tested in these longitudinal studies that they've had, they're showing functioning within the normal ranges, but it's at the lower end of the normal range, which is still okay. We can make accommodations and we can support children in these situations when they need it. But they might have, again, they might be poorer than a control group, but they're still within the range of normal. Does that make sense to everybody? So it's just something to look out for. And some kids take off in the areas of motor development and may have delays in other forms, in other areas of development. They might be really active kids too. Okay, I'm gonna, hold on, sorry. I know my time's. Okay, so for school-aged kids, their speech and language development, you'll just see what all of these studies are suggesting, that children who are born having been exposed can experience learning challenges in childhood. And so it goes back to that first stage. We really need to be interactive with their children and really kind of ready to learn from them and parent them in a different ways to support that, those different areas, and recognize possible differences. And then always react in a way that provides them with extra support if we feel like they're needed. There's more and more studies coming out that are saying that there are long-term effects in language development, both receptive and expressive, which will definitely impact, speech and reading. And it really, they're recommending a lot of developmental surveillance and just staying on top of some of these differences that we're seeing early in childhood. You're seeing some of the samples up here with the more the longitudinal percentages. So it is definitely decreasing as children get older, but it is still a difference, a significant difference between 12 and 24. And so the real question becomes, when do we bring it up to school? And I have a really nice handout for you that we've added to the resource list on our website about what differences we might see and how to approach them as kids enter school. The cognitive development, I believe, is really, again, going back to the areas of the brain that are most impacted, like the limbic system, the amygdala, and the cortex, the gray cortex. We see a lot of differences in attention, and they call it neurocognition. So that's really looking at the ability to really focus on a task, understand what's going on, take in that information, commit it to memory, and then use it in a constructive way to build learning. And so I think that can be really difficult for children with NAS and NOWS, because it's just a lot harder for them to regulate their bodies and to get into a space where they're paying enough attention, or they're able to pay enough attention to really take in that information and process it in a way that's going to be beneficial to their learning moving forward. So overall, as children get older, we are seeing that some of the boys are scoring lower on the assessments, especially around the cognition. And the girls, they scored lower, but still didn't have a significant difference. So, you know, it's really showing up more in the males with prenatal exposure, that they often demonstrate the lower performance. And I don't know, again, what kind of expectations were built in for these boys, or what type of learning environment they were provided, what type of supports in that environment. I think a lot of times boys in general have a harder time in the traditional classrooms and with those expectations. So it's difficult to pull out all the differences that are impacting, or the confounding factors that are impacting some of these outcomes in the studies. So the infants, though, definitely we see a lot of fussiness, difficulty regulating. They have a hard time eating, and their respiratory systems can be affected. They're going through their tremors, and it's just their sleep cycles are disrupted. And it's a time where the response and from the caregiver is very important, but it's also, these behaviors are also can be very challenging for caregivers to have patience with and provide the most nurturing caregiving, especially if the caregiver is compromised in any way and maybe they're not able to regulate themselves, then it can be a very difficult time for infants. And so sometimes these patterns are established really early on that carry into later childhood of sensory, they become sensory seeking, and they just have a really hard time calming themselves to a place where they can accept and get into a place where they're organized for learning and interactions. Again, we often see tantrums, hyperactivities, sensory issues, and then these disrupted sleep cycles, which impacts all the other areas of development. And so we really, I think, looking at the behavior first and getting intervention in place can be one of the best strategies for these children. Again, in childhood, we're seeing more regulatory problems. And so I know I'm preaching to the choir here, but it really is something that we need to consider when we're talking to teachers and to people at the school to help them realize that there's more going on here than just misbehaving. There's better explanation, and we need to understand what are the prenatal exposure actually represents. in children. So this is the handout I put on I'm going to stop share and share it again. That I put on our website that I have found that it was actually developed by an adoptive parent who was working on her master's in education and is a principal at a specialized school in Cincinnati. And so I don't know how easy it is to read on this format, but she talks about all these areas. There's sensory struggles, anxiety, impulse control, ADHD, motor skills, frustration regulation, speech and auditory processing. And she just lays out questions that we consider for each of these areas. And then also explains or gives possible go-tos. Like, if we're suspecting sensory struggles, like we see kids who are really irritable or sensitive in busy places, or, refusing to eat or very picky eaters, then it would be recommended to see an occupational therapist for an evaluation. With anxiety, if we're seeing a lot of kids who have, gastrointestinal issues, overly worried, then we might want to see a psychologist or a developmental pediatrician. So these are just some strategies and some things to be aware of, what to do, talking with you, how to talk to your school, what you might want to ask for. I just found it a really great resource that I think needs to get out far and wide as we see more and more of these kids growing into the school age population and still continuing to need the supports in place as they grow older. So yeah, it's like I said, it's on our website, so you can have it. If you need me to email it to you, I'd be happy to do that as well. If you need, I would share copies of this if you have children in your life who might benefit from this type of mindfulness from their schools or their teachers. I think it's a really easy to understand resource and a great one to hand out to anybody who's involved with children, period. So I know that's fast. I know our trainings always kind of go quickly, but does anybody have questions, or do they want to just kind of start a conversation or have comments about what you've seen in your experiences? What's worked, what hasn't worked? Any other ideas that want to be shared right now?
A question while it's in my poor sleep deprived brain.
Yeah, right.
I'm curious if we know why the respiratory problems, and also if there's any recommendations you have for resources or books where you can dive deeper on this subject, because I have a hard time finding stuff online on it besides just kind of surface level stuff.
Right. Yeah, I will try to get some of those websites and share them. We have some resources on our website, and I'm not sure, I haven't looked at them in a bit, to be honest with you, but I can go back and update some of them too. The sleep, I think a lot of this, or the respiration, I know, a lot of these babies also have reflux, and I think that can influence their respiration, but they also just kind of have narrow passageways and they're not fully developed. Oh yeah, sorry. If somebody could put our website in, that would be really great. And I can share these slides. I'd be happy to. And we'll have a recording of this on our website as well. But Sally, the babies that I have seen and worked with, this would be a great question for Dr. Rice when she comes back. And she did the presentation on the NICU and infancy, but they just seem to have very small airways and that are just always clogged, or that they just have a poor immune system, possibly because of, not getting very good prenatal care. Their moms typically aren't, either there's a myriad of reasons that a lot of these moms don't get good prenatal care. One could be a stigma attached to a mom who reports she has substance use disorder. Another is that she's just not in a place to get in to see the OBGYN. But anyway, a lot of the babies are born kind of more immunosuppressed because they haven't had, great prenatal health. And so I think that often also leads to the respiratory issues and therefore the sleeping and the eating. They're all interconnected.
Yeah, that makes a lot of sense. Thank you.
Sure. Yeah.
I have a question. Sarah, could you speak more to GI issues or tummy issues?
Yeah, we see a lot of kids with reflux. And so they have, and a lot of times it turns out, I think their GI issues, especially, I see it more longer lasting with kids who've been exposed to meth. Their tummies are just really upset all the time. And they may not have the reflux that pediatricians expect to see with a lot of spit up, but they may. They often have a lot of spit up, but they might have more of a silent reflex where it's still bothering them, but they don't, the more obvious signs aren't there, so it goes unnoticed. But a lot of babies need more sensitive formulas, or they benefit from different reflex medications. Oh, there's your puppy. And, they're just, and they also, so the other part of the GI issues are really extreme cases of diarrhea, and diarrhea, especially in the babies with meth, that's really caustic, and that causes really severe diaper rash, and takes a lot of constant care, and so it definitely also causes the reflux. Going back to the upper GI, the reflux causes feeding issues. The babies don't want to feed. And so the recommendation for infants is to feed them, a lot of times high calorie, but short doses over more frequent feedings. So they have a chance to digest it without filling up their bellies to the place where they might have experience more of the reflux symptoms. Yeah.
I am sort of wondering about the link, and I haven't looked up any data about this, but I'm wondering if there is some predisposition for babies who are exposed in utero to autism spectrum disorder.
There is a lot of talk about that, Navita, and a lot of babies or younger children who've been exposed to trauma. And a lot of caregivers or practitioners who kind of see the symptoms that are similar to autism in those who've either been exposed in utero or gone through, living, have a high ACEs score, have a lot of trauma. And those symptoms, because their communication isn't developed very well, and there's a huge lack of resources like yourself in communities to address some of that early trauma, that a lot of that gets intermingled and it's really hard to tease out. The developmental pediatrician I work with, we have a clinic here at NAU where we do interdisciplinary evals. And a lot of times if the child's ACEs score, if they have a history of trauma, but they still look autistic, she'll avoid giving them that diagnosis until they've had some type of mental health supports in place. So they can definitely mirror each other, I think, but especially those anxiety pieces, like maybe having those stereotypical behaviors such as or those sensory behaviors that might look autistic, but really are coming from a place of anxiousness or poor relationship, going back to the relationship insecurity, the insecure attachment, things like that. So we really need to be mindful when we're considering those two and work all together as a community to get better tools and better training on how to differentiate the difference. But I know Kirsten's, but like I don't know if you're familiar with the neurosequential model. And blank, what's his name? Bruce Perry. I was like Bradley. Bruce Perry's work is a really good resource for a lot of these kids because I think it helps us look at them in a really nuanced way and understanding what might be going on for them and their behaviors might be communicating when they can't communicate themselves because either the trauma happened too early and they don't have, the accurate memories or the skills to tell us what they're going through. So I think those are models we really need to start to integrate into our practices more thoroughly.
For sure. And, obviously there's a lot of, polyvagal, work
Yes.
that can be done. And you're right. So often the symptoms are overlapping and there may be a lot of similarities of either the symptoms because of what they experience in utero or trauma, or, even symptoms of, attention deficit disorder versus autism versus oppositional. So there's so many, overlapping pieces there. But I just wondered in terms of, the data and what's out there. So maybe something I'll research and get back to you guys, but of the link between exposure in utero and ASD. So, I know 2 cases personally that, the kiddos did get diagnosed with that. And one was a kiddo that we fostered and one was a friend of ours that foster adopted. And it's just really interesting to just wonder if there is sort of a link there as, everything that you are talking about and everything we're trying to do, early intervention is key to, help these kiddos be able to form different, neural pathways and different ways of connecting and communicating. But yeah, just kind of wondering about that connection. So more to be revealed. And yes, I'd be happy to present again and either talk about, any of these other kiddos or not, my own story. I didn't have addiction in or in utero, but out of utero, a lot of that exposure as a child. So from parents. So happy to present on that anytime if I'm available.
Being so open and sharing. We really appreciate that. Yeah. So I know I ran over, I'm sorry. But Nicole is going to do a case presentation. And if it's okay with you, if you all, do you want a break? Would that be good? I feel like we're rushing. Maybe we could take it like a 3-minute break just to kind of get up and stretch for a second or two. And then Nicole is going to do a case presentation. I can stay on. Why don't we come back at like 11:55 just to make it easier, the math easier. So if anybody has any questions, I'll stay on and we can keep talking, but we'll get ready for Nicole at 11:55. Thank you all for all your participation too.
Hello, this is Khadijah.
Hi, Khadijah. How are you?
Hi. I was wondering, oh, you know what? No, I'm looking at your website. I'm okay. Or the
Okay.
website. Where do we find the recorded training?
I'm sorry, what are you looking
I'm
for?
sorry, where do we find the recorded training?
Oh, okay. So they are, if you go to the session schedules and recordings, do you see that drop down? I can share my screen.
Yeah, I think I'm there. Where,
Okay.
yeah.
So just scroll down where you register.
Okay.
And it's, the first one is the NICU and infancy. What does NICU look like?
Thank you.
And then
Yeah, it
there's,
just has the link that says register here.
yeah, well, let me share with you and then,
Yeah,
Okay.
scroll a little bit past the block of sessions and you'll see
Okay,
the
yeah, that's-
videos.
do you see my,
Yes.
do you
for
see the,
sure. Oh, okay, recording. I didn't scroll down for it.
okay.
Right there. Yes,
Yes.
thank you.
And then
that's-
we'll
Okay.
be adding,
and
and
then
this-
there's a 2021 playlist, so you can go back and look at the other ones as well.
Oh, awesome.
yeah,
Okay.
that's from our fall training initiative. And then the resources, we're trying to collect them and add them down
Oh,
at the bottom here.
oh, awesome. Thank you so much.
You're welcome. Yeah. no problem.
Unfortunately, I missed a lot right now because I was just trying to make sure my doorbell didn't catch on fire. So
Oh my gosh.
I missed some stuff. So
Well,
okay,
if you
I'll-
ever want to just chat, I'm always available.
oh,
This is
thank you
kind
so
of
much.
a passion project of mine. So
Are these others all still open for registration?
yeah, we don't have a cap on registration, so feel free
Okay.
to register for any of them that you can.